Right. So in the last session, guys, we had a talk about some of the methods of the contraception, right? Among which we have talked about some of the natural methods, some of the barrier methods, right? Where we had to talk about the condoms, male and female condoms. Then we had to talk about the intrauterine contraceptive devices, where I have talked about the several generations of that. That is first generation, second generation, the third generation, right? Among which we had to talk about the differences between the multi-load 375 and the copper T 380A as well. Those are the major copper Ts which we are using for the contraception purpose, right? So in this particular section, basically this is the continuation of that section only. So in this particular session, we are going to talk about some more methods of contraception and the sterilization, right? Okay, so let's continue with that. So the very first one which I'm going to take over here, that is the OCPs, guys, right? Okay, so let's talk about the OCPs, right? So everybody knows that. So OCPs, basically these are the oral contraceptive pills, right? These are the oral contraceptive pills. Basically these are the combination of estrogen and the progesterone, right? So basically these are your combination of estrogen and the progesterone, and very well you are aware with that, right, from other subjects also, like from the physiology and other things, that estrogen and the progesterone, these are the hormones, right? And so basically this is the combination of that. So basically from outside we are giving these hormones to the lady, right? Okay, we'll not call them patient, but over here we are giving them as a contraceptive so that they can prevent the pregnancy, right? Okay, so over here if you talk about India, right, if we talk about India, obviously we want to promote this contraception and basically the oral contraceptive pills. And usually if you talk about these are almost very best kind of contraceptives we are having, because the Pearl index, which I have talked about in the last session also, that in the Pearl index we are talking about the contraceptive failure, right? So contraceptive failure chances are pretty low in the uses of oral contraceptive pills, right? So basically these can also be called as the combined pills, because we are combining the estrogen and the progesterone over here, right? Okay, so in India, basically we from the government of India side, right, in the market, okay, we are having two kinds of tablets, right? One is the Mala N and one is the Mala D. You might have heard about that as well. So Mala and Mala D, actually these are the oral contraceptive pills which are available from the government of India sides. And the ASHA worker, basically who are working at the level of village, right, they will be promoting these kind of contraceptives, and they will be going to doorsteps of the people living in the villages, and they will try to distribute among them, right? So basically the ASHA will be given the incentive also for doing that. So over here basically we are having two kinds of contraceptives. Okay, which kind of contraceptive? First one we are having A, that is the Mala N, right? Mala N, which you can see over here right now in front of your picture. This is the Mala N over here. Okay, so in the Mala N, basically this is the contraceptive pill. Okay, and this is not for sale basically, because it is a government supply. So basically in the Mala N, what is the combination? Estrogen, progesterone. So to be very specific, we should know the basic combination over here. So it is containing actually the levonorgestrel, that is the LNG, levonorgestrel, that is the LNG, that will be around 0.15 mg in this tablet, right? With that we are having the ethinyl estradiol, right, that will be present as 0.03 mg, right? So I told you two tablets from the government of India side, right, they are promoting for the contraceptive purposes. So oral contraceptive pills, one is the Mala and one is the Mala D. Both of these tablets are containing the same combination only. One estrogen, progesterone, I mean the levonorgestrel, that is the 0.15 mg, and the ethinyl estradiol, that will be the 0.03 mg. This combination is valid for both of them, right? So Mala and Mala D is probably the same only, right? But the basic difference which we can understand over here between these two, that Mala N is provided free of cost to the people, right, to the community, basically in the villages and all, right? And then Mala D, actually it is available for the social marketing scheme, right? So Mala N, actually it is actually available free of cost from the government of India side. It is available free of cost. And if you talk about the Mala D, right, the combination will be same as I told you. Levonorgestrel, that is 0.15 mg, ethinyl estradiol, that is 0.03 mg. But over here the basic difference is that it is available under social marketing scheme, and basically the Mala D is actually available, it is actually given to the ASHA, and ASHA will be giving it to the people at the cost of rupee 1, right? At the cost of rupee 1, that is a negligible cost only. So that is the basic difference between Mala N and Mala D. So Mala D will be given to the ASHA, and ASHA will be providing it at the cost of rupee 1. Okay, so that is the Mala D basically, and the combination will be same, right? So one more thing which is very important over here, which I wanna add over here, that in the Mala D, basically I told you that it is available under social marketing scheme, right? So available under social marketing scheme, right? Social marketing scheme, it means that the ASHA worker will be distributing it, okay, right? So ASHA worker will be giving it, okay, at the village level she is working, so ASHA will be giving it to the people who are living in the villages at the cost of ₹1, right? Okay, so ASHA worker will be giving it, okay, and the ASHA worker, she will be getting the incentive from the government of India side for providing these malady and the mala and also, right, to the people basically, right? So basically these kind of mala and malady tablets, right, they are very frequently available and they are distributed, and the government of India is actually trying their best that every home in the basically in the villages, okay, it should be provided to them, so that we are actually achieving the contraception. So that is the thing over here. So ASHA worker will be providing this, will be providing it, right? For each distribution of the malady, basically she will be getting, ASHA will be getting the incentive from the government of India for everyone, okay, fine. So both of these tablets, guys, both of these tablets, right, so both tablets are containing what? I told you estrogen, progesterone, I told you the composition also, but both tablets are containing the 21 hormonal tablets and the 7 iron fumarate tablets. So over here, we are seeing that they are containing the 21 hormonal tablets. These are the combination of estrogen and progesterone. With that, 7 iron tablets are there, 7 iron fumarate tablets are there, right? So total how many tablets we are having? So total we are having the 28 tablets, right? So total we are having how many? We are having the 28 tablets. So that is very important for us to know, right? Next thing over here, guys, if you will be seeing the packets of these ones, so this is the mala N which you are seeing right now. This is the mala D, right? In the mala D, you are seeing that what is the combination? Levonorgestrel and ethinyl estradiol. Levonorgestrel will be present as 0.15 mg and ethinyl estradiol will be present as 0.03 mg. Okay, with that we are having the ferrous fumarate also, that is the 7 tablets of the ferrous fumarate, and here we are having this one, how many tablets? 21 for 21 days, 1 tablet each day, so 21 tablets, right? 21 hormonal tablets, they are present over there. Again, this is under governmental supply, not to be sold. Okay guys, now this is the packet. When you will be opening this packet, right, when you will be opening this packet, what you will be seeing basically the instruction for 28 tablets pack. Okay, so what is written over here? The first course should be started on the 5th day of the menstrual cycle. That is important. If some couple is actually starting this tablets, if some female in this particular couple, to what couple we are targeting? This is the eligible couple. I told you what is the eligible couple, newly married couple and all, right? Okay, so for the target couple, I told you we will do the sterilization. For example, vasectomy, tubectomy. Vasectomy is preferred because it is cost effective. And for the eligible couple, we will be trying to give the contraceptive as oral contraceptive pills to them, right? So over here, 5th day of the cycle they will be starting, and usually it is advisable that at the bed time they can take it. So while going to bed, they might be taking it, right? She might be taking it. So basically this is very easy to understand for every kind of person. If the couple is also uneducated also, then also it is very easy to use. Actually, we ASHA worker will be actually explaining them that they have to take this tablet, 1 tablet a day, and usually at the bed time they can take it, right? And there is no side effect of these kind of things. They will be actually explaining them, and what could be the side effect, contraindication, okay, they will be telling them. So after that they shall provide them, right? So basically here you can see that at this point of time you can see that it is starting point, and this is the ending point of this particular OCP. So at each day you will be seeing that till day 21 over here, right, you are having the hormonal tablets, and then day 7 these are the ferrous fumarate, these are the iron tablets only, right? So that is the thing over here, and that's how we are using it. Okay, so once you have understood about this one, right, then we shall move on to the next section over here, that is the mechanism of action, how these kind of OCPs are actually working. So that is also very common question which is actually asked. So what is the mechanism of action? I'm just writing MOA, that is the mechanism of action. So basically it is very easy to understand. Actually it is preventing the ovulation. It is preventing the ovulation, or it is actually preventing the exit of the oocyte from the ovary, right, or exit of the ovum from the ovary, right? Basically it is preventing the ovulation, and you know that if the ovulation will not be happening, then obviously the pregnancy chances are reducing drastically, right? So that is the thing over here, and that's how it is working. Second thing is it is preventing the implantation as well. It is preventing the implantation as well. Okay, and with that it is actually making the cervical secretions or making the cervical mucus thick in nature. Okay, and we know that if the cervical mucus will become thicker, right, then obviously it will not be suitable for the pregnancy, right? So it is preventing the ovulation, it is preventing the implantation and making the cervical mucus thick. And we know that for getting the pregnancy, for having the pregnancy, cervical mucus should be thin, right? In the last session I have talked about the Billings method. In the Billings method I told you this is actually based on the cervical mucus secretion. So cervical mucus is actually getting thinner at around day 14 of the menstrual cycle, right? So at that point of time, that is the unsafe period for the sexual intercourse, right? So at that point of time, the couple who do not want any kind of pregnancy, so they should be avoiding the intercourse at that point of time, right? So over here, if the cervical mucus will become thin, obviously it is not favorable for the pregnancy, right? So that is the basic idea over here. Now next point over here is that it is having a very high effectivity also. So that's why it is having 98 to 99%, even more than that effectivity if you talk about over here. Okay, and Pearl index is quite low over here. So guys, it is most effective contraception we are having, right? So that is the thing over here. Now there could be some side effects also, right? There could be some side effects of in the medication, right? We are having very limited drugs who are not having side effects, right? So there could be some side effects also over here, right? However, they are not very common, so let's talk about them as well. Okay, so first one is the metabolic side effect, right? For an example, if some female is actually if some female in the couple, she is taking these contraceptive for a very long period of time, they might be getting extra amount of fat, they might be getting obese, right? So there might be the obesity factor, right? There might be the obesity factor. With that, there might be the dyslipidemia, right? So lipid levels might be disturbed over there. Second one which I want to highlight over here, so they might be having some cardiovascular side effects also. In the cardiovascular side effects, I will be talking about, for an example, the hypertension might be there, the hypertension risk is there, CAD, right? Stroke risk is there, but they are very minimal, right? They are very minimal. They are not that common, right? So they are very minimal, but we should know about them, right? Okay, so that is the thing in the DVT. So obviously you should understand that if some person is having already these kind of things, for example, if some person is hypertensive, mild hypertension, or some person is having the coronary artery disease episode, or some person was having the cerebrovascular stroke, some person was having the DVT or pulmonary embolism, right? So these kind of symptoms, if these kind of things, these kind of syndromes, if these kind of symptoms are present in any kind of female, then obviously you'll be avoiding to give contraception in those cases, right? Because we are actually giving the exogenous hormones, right? We are actually giving the estrogen, progesterone only, right? So they can actually disturb these kind of syndromes, right? Okay. Then next one we shall talk about, there might be some malignancies also. In the malignancies, very commonly they ask you, okay, because that might be confusing. So in the malignancies, very commonly ask you that OCPs are promoting which kind of malignancies, and OCPs are protective for some kind of malignancy, right? So over here, be very clear that if we talk about the protective nature of OCP, right? So it is actually protective for the ovarian cancer or ovarian carcinoma, right? Okay, that is the best answer. Or endometrial carcinoma, right? So if ovarian is not given in the options, then you might go for the endometrial, but usually it will be provided with the option. So ovarian CA is the cancer where it is actually protective in nature as far as OCPs or oral contraceptive pills are concerned. And if you talk about promoting nature, right, they are actually promoting some kind of cancer. So obviously you will not be actually providing the OCPs in those kind of patients, right, who are having these kind of cancer. Which cancer I'm talking about? For example, breast CA, right? Breast CA, cervical CA, right? But the best answer over here, I will be saying that it will be cervical CA. So I will be writing cervical CA first. So cervical carcinoma, then breast carcinoma, right? And with that, we should actually make sure that it can actually cause the hepatocellular carcinoma as well. So a patient who is having some kind of disease regarding the liver, they should be avoided over here. So liver disease, any kind of liver disease also, that will also be the contraindication, or you might say that can be the side effect over here. Okay, so this is about the side effects over here as far as OCPs are concerned. Now let's move on to the contraindications, right? Now let's move on to the contraindications. So what could be the contraindications, right? I'm just writing this sign. This is a contraindication basically. So what can be the contraindication as far as OCPs are concerned, right? There could be two factors. So one could be the absolute contraindications, right? And one could be the relative contraindications as far as OCPs are concerned, right? So let's talk about them, right? Obviously, once we have talked about side effects over here, so we are pretty much clear also that in what cases we should not give contraindication. Means we should not give these drugs in what kind of cases or what kind of diseases, right? So obviously we talked about that they are having promoting nature for the cervical carcinoma, breast carcinoma. So over here we should not be giving them, right? So for cervical carcinoma or the breast carcinoma, we should be avoiding these pills, right? Then these are the absolute contraindication. Along with that, if some patient is having liver disease, because it can cause the hepatic diseases, it can cause hepatocellular carcinoma, so obviously in those patients will be avoiding these kind of pills, right? Some patient is having DVT, that is a deep vein thrombosis, right? Or it might also lead to the pulmonary embolism. We know that, right? If the thrombus will be converting into the embolus and it can actually travel up, right? So that can cause pulmonary embolism. You know that from medicine side. So in the PE also, in the pulmonary embolism also, we should be avoiding in giving these kind of pills, right? If some patient is having abnormal uterine bleeding, what is AUB? Abnormal uterine bleeding. If some patient is having that also, we should be actually avoiding this. If some patient is having some kind of cardiac diseases, right? Some kind of cardiac issues are there. For an example, let's say CAD episodes, or let's say there might be some heart diseases, right? It might be the ischemic heart disease, it might be some kind of angina, something like that. We should be avoiding these kind of pills, right? What will be the relative indications, right? In the relative indication, if the female is in itself, if the age is more than 40 years, or if she is a smoker, in that case, if age is more than 35 years, we will be not giving these kind of pills, right? Then second thing is, like if some patient is having, let's say, migraine, okay, if some patient is having epilepsy, or if some patient is having, we saw that mild hypertension, right? Mild to moderate hypertension, right? Some patient who is having the lactation, who is on lactation, right? We will be avoiding these kind of pills. So OCPs are avoided in the lactational amenorrhea or in the lactation basically. And I told you, if you want to give the contraception of choice in the lactation amenorrhea, I told you that was progesterone only pills, right? Be very clear with that. I told you those are the mini pills. So progesterone only pills should be given during the lactation period, not the oral contraceptive pills, right? So that is your MCQ as well, right? Okay, with that, if some patient is on amenorrhea, right? So the list is actually long as far as relative contraindications are concerned, but absolute contraindications are you have to remember them, you have to know them, okay, right? So once we are clear with that, now we shall move on to the implants. Before moving on to the implants, one more thing over here I would like to mention that basically if you talk about the OCPs, right, they're actually preventing what? They're preventing the ovulation. So basically they are actually causing the anovulatory cycle. So be very clear with that, they are actually causing the anovulatory cycles, and that might be the side effect also of it, right? Okay, so second thing is how they are working actually. I told you they are having the 21 hormonal tablets, that is the estrogen progesterone combination, and second I told you ferrous fumarate for the last 7 days of the menstrual cycle, right? So if the person will be taking these tablets day by day, right, what will happen after the 21 days? Then they will be shifted to the iron, right? But they might not be knowing it that they are eating the iron tablet only, okay? So that's how it is given, okay? And Asha is actually explaining to them that they should be taking it in that manner which is actually given on that card which I showed you, right? It's not that first of all they are taking first tablet, then they are taking last tablet, randomly they should not take this one. So they should be explained to the user also, right, by the Asha worker and all. So that is the thing over here. So once at the 21st day, she will be taking it this again hormonal tablet. At the 22 day, 23 day, 24 day, 25 day, they will be taking the iron fumarate tablet. So sudden abrupt stop or sudden cessation of these particular hormonal tablets will cause the withdrawal bleeding, right? Will cause the withdrawal bleeding, and that's how they are working basically, okay? And we know that in the pregnancy, the patients are not having the bleeding, right? So that's how the bleeding is happening, and that's how they're not having the pregnancy. That's how it is prevented, right? So basically it is their body is actually working on the exogenous estrogen progesterone combination, right? So once you are clear with that, now we shall move on to this one. One more point, the drugs which are causing OCP failure, drugs which are causing the OCP failure, right? Once they have asked you which of the following drugs is causing the OCP failure. So here some drugs over here, for example, please remember the rifampicin or rifampin, phenytoin, right, and phenobarbital, right? So these drugs must be remembered, okay? You can remember them by the help of RP, right? Recently, this was a highlight in the social media. So basically RP is it's not that RP which you are thinking, this is the R for rifampicin and P for phenytoin and phenobarbital, right? So please remember that the drugs which are causing the OCP failure. Now we shall move on to the implants. Okay, so one more method which we shall talk about over here, these are the implants. So we have talked about the OCPs, right? Very important. Now we are coming to the implants. Okay, so in the implant, basically we are talking about the subdermal implants, right? We are talking about the subdermal implants. Okay, subdermal implants. And let me tell you over here that these kind of implants are having very high effectivity rate. So they are having very low pulse index, right? So they are very effective actually, right? And at the same time, they might be effective for 90 to 99% of cases. And usually they are getting actually, we are actually giving these implants in this particular area, that is near the triceps area or the posterior part of the arm. Okay, so in this area we are giving that. For example, right now in front of your screen, you can see that this is NOR plant basically. Okay, these are the strips over here which are present over here, right? And through this particular, device, we are actually putting these on the surface, on the body surface. Basically, these are the subdermal implants. Okay, fine. So very first one, if we talk about, then we are having the NOR plant. We are having the NOR plant. So we shall talk about, that is the NOR plant basically. Okay, and you can see right now on your picture that how is it looking over here, right? So basically these are made up of silicone and the plastic. Okay, these are the celastic rods basically. These rods which you are seeing over there, these are the celastic rods. Okay, so it is actually made up of silicone plus plastic. Okay, and they are actually celastic rods over here, right? There are the celastic rods, and actually they are actually coming like R6, R4, R2, etc, right? R4, basically we are talking about R4, these are the silicate rods. Okay, so R4, they are the celastic rods, right? Celastic rods means these are R, right? Okay, once we are clear with that, now what is implanon and what is nexplanon? If you talk about all of these subdermal implants, right, nexplanon is the best subdermal implant, right? So let's talk about the second category over here. Actually, this is the implanon and nexplanon, right? Implanon and the nexplanon. Here you can see this is the implanon. Basically, implanon is coming like this thing, right? Like a stapler kind of thing over here. So on the posterior aspect of the arm, basically they will be actually introducing it in this direction, right? So you are seeing that this is the implanon, right? So how they are inserting, right? So once you are clear with that, let me talk about this implanon and the nexplanon. They will be containing over here, that is the etonogestrel, right? So they will be containing, they contains, right, etonogestrel over here, right? If you will be seeing this picture, right, I'm zooming for you over here. So here you can see this is the etonogestrel, right? If you will be, I don't know whether you are able to see that or not, but this is the etonogestrel. Okay, right? So once we are clear with that, this is the etonogestrel. Okay, so it is containing what? It is containing the etonogestrel, right? So basically what it is doing, that it is actually secreting this hormone. It is actually secreting this hormone at the rate of around 60 to 70 microgram per day, right? Secreting at the around 60 to 70 microgram per day for 30 to 60 days. Secretes 60 to 70 microgram per day of etonogestrel, right, for about 30 days, for about 1 to 2 months, or 30 to 60 days over here, right? After that, this particular rate will be decreasing, and it will be secreting from 25 to 30 microgram per day for the rest of its time, right? So then it will be secreting, right, 25 to 30 microgram per day after 2 months for rest of the days, right? And basically it is effective for how much period? It is effective for quite long period, that is 3 years, right? It is effective for about 3 years, right? Okay, one more thing, nexplanon, I told you that it is kind of a best contraception in the subdermal implant category, and this is having what? It is having the least failure rate. So nexplanon over here, nexplanon we are having, that is having the least failure rate. So once has been asked, so please remember that as well. So nexplanon is having the least failure rate. Okay, so here you can see this is the nexplanon. So this is the nexplanon. Okay, kind of a one implant over there, again at the posterior aspect of the arm. Okay, this is a subdermal implant, so this will be given over there. Okay, this will be implanted over there. Okay, once we are clear with this these kind of subdermal implants, right, we shall now move on to the injectables, right? Now we shall move on to the injectables. Okay, in the injectables, very commonly or very popularly, okay, you might have heard about this, that is the Antara, right? So basically this is the injection. It is coming as DMPA, DMPA, okay, DMPA, it is the depot medroxyprogesterone acetate, right, depot medroxyprogesterone acetate. And basically what it is, this is actually coming in the 150 mg form, right? It is given intramuscularly for every 3 months, right? So over here, this is the 150 mg dose, okay, which is coming in the intramuscular form, right? You are giving it intramuscularly for every 3 months, right? For every 3 months. Government of India is supplying this, right? Government of India is supplying this. Firstly, initially they had actually released this, these injections, and they named it as Antra basically. So very important. So Government of India released these injections, DMPA, by the name of, right, the very popular one, that is Antra. Okay, as you can see the image over here, right, you can see that this is the medroxyprogesterone injection, that is 150 mg per ml, right? It is given intramuscularly every 3 months, right, every 90 days. So this is the Antra over here. Okay, so this is the contraceptive injectable. This is the injectable contraceptive, right? So once you have understood this, okay, it is coming under National Family Planning Program. Okay, this is the logo of the National Family Planning Program. Okay, so we'll be talking about that in the next chapter. Okay, right. So once we have talked about that this is the Antra, right, and it is given 150 mg IM for every 3 months. Okay, then it is how it is acting, right? What is the mechanism of action over here? So basically this is actually acting by bringing the changes in the cervical mucus nature. Okay, so acting by thickening of cervical mucus, again over here. So thickening of cervical mucus, so it is actually changing the nature of the cervical mucus, right? Okay, then it is actually preventing the ovulation as well, same like OCPs. It is preventing the ovulation and making the endometrium hostile. Okay, this is also one more function over here. So it can be used where we cannot give the OCPs, we cannot give the intrauterine contraceptive devices. In those kind of cases, right, for example, these two kinds of cases are the female is not very suitable with that, or the female is having the contraindication for taking those OCPs or the intrauterine contraceptive device. So in those kind of cases, she might be taking this Antara, right? That is the DMPA injections every 3 months, 150 mg intramuscularly, right? Okay. Now one more thing over here, that what could be the disadvantages if you talk about the Antara, right? So what could be the side effects over here, or the disadvantages if you talk about Antara, right? So basically in some patient there could be the spotting, right? Or in some patient there could be the immediate PV bleed. PV means pervaginal. So immediate pervaginal bleeding might be seen. Again, it is not very common, right? So that can be seen, but we should know about that, right? So that is about Antara, which is the injectable available from the Government of India side with the name of Antara. So now let's talk about some other methods of contraceptions, right? So very first one over here, that is let's talk about the Centchroman, right? Centchroman. You might have heard about this Centchroman as well. So basically Centchroman is actually, what is this? It is actually 30 mg of methoxychroman hydrochloride, right? That's how it is named as Centchroman. So methoxychroman hydrochloride, that is present as 30 mg over here, right? So basically this is taken once weekly, right? This is not the daily pill over here. So once weekly. So it is taken once weekly. That is kind of a advantage of this particular pill. It is taken as once weekly, and it will be forming one active metabolite over here. Okay, it forms one active metabolite, very popular one, active metabolite, that is the ormeloxyfen, right? So it is making one very important metabolite over here, that is actually tested very commonly in the exams as well, that is the ormeloxyfen, right? So ormeloxyfen is present over there. So basically, Government of India launched it initially with the name of Saheli, right? You might have saw some kind of advertisement in the television also. So they were actually releasing it with the name of Saheli. Then they changed it, and now it is coming as a name for the name of Chaya. So these are coming as Chaya tablet, that is the Centchroman, right? So initially it was coming as Saheli, which is not available these days. Now it has been replaced with the Chaya basically, right? So these are the oral contraceptive we are having. This is actually the weekly pill we are having, that is the name of with the name of Centchroman, that is coming with the name of this one, that is a Chaya, right? So here you can see from the government of India, this is the free supply over here, right? Not for the sale basically. So what we are seeing, how we are giving it. So in the very first go, we are giving it 30 mg on the day 1 of the menstrual cycle. We gave it 30 mg on the day 1 of menstrual cycle. So let me write over here. So how to give this, right? So it will be given at day 1 of menstrual cycle. And how much you will be giving it? 30 mg. I told you that 30 mg methoxychroman hydrochloride, right? So we are giving it as 30 mg. This is the dose over here which we are available with, right? Then we are giving it, it is a weekly pill. So then after that we are giving it twice weekly for the first 3 months. Then twice weekly for first 3 months, right? And with that, after that, in the subsequent coming months, we'll be giving it one pill in a week, right? That is a weekly pill over here, right? So after that, we'll be given one pill per week for coming months, right? For coming months. So this is the method of taking it. So first of all, at the day 1, we'll be giving it 30 mg, then twice weekly for first 3 months, and then one pill weekly for the subsequent coming months, right? So that is the way of giving it. So that's how they have mentioned it over here as well. It is containing the 8 tablets, and they are saying that twice a week for first 3 months and once a week after 3 months, right? And before that, day 1 of menstrual cycle, how much you are giving? 30 mg, right? So we have talked about that. This is the Chaya. Okay, they are containing the Centchroman. This is the 30 mg tablet. Okay, once weekly, and they are very high potent OCP. They are highly potent OCP over here. These are actually highly potent OCP, right? So they are highly potent, but because it is once a week pill, right? So if they are taking once a week, then it is good. But let's say if they have missed it, right? So there is very low compliance from the people side, right? So in the uneducated people, we can't give it, right? So because they might be forgetting it or something like that. So usually we are using it in the urban areas, and right, and basically the compliance rate is very low over here. That's why the failure rate might be seen over here. So they are not very compliant. So highly potent but less compliance is seen, right? Along with the uses and all of these things, right? Okay. So once you talked about that, now we shall move on to the emergency contraception, right? Emergency contraception. So let's talk about the emergency contraception. So let's talk about that, right? Emergency contraception means that, one couple, they had a sexual intercourse, right? Obviously that was unprotected sexual intercourse, and now the female didn't took any kind of contraceptive pills, right? So now for the emergency purpose, right, what kind of pill we shall give over there? So basically it is coming, the one pill which is coming very commonly used, that is the levonorgestrel, that is the LNG, right? Levonorgestrel, and it is giving with the dose of 1.5 mg, right? 1.5 mg we are giving it, single dose tablet, right? That will be taken basically within 72 hours of unprotected sex, right? So you might have heard about the advertisement also, I-pill, right? I-pill 72, take it within 72 hours and get rid of the pregnancy, right? So basically that was this levonorgestrel only, that is given 1.5 mg. Initially the doses were different, right? Now we have increased the dose, that is the 1.5 mg, and only single tablet will do the work. So this tablet basically will be taken, one tablet to be taken within 72 hours. Okay, the sign is for within, right? So within 72 hours, that is very important. Okay, please highlight that. So within 72 hours. Okay, so that is the thing over here, right? But if the 72 hours will be crossed, right, there is no guarantee if it will be preventing the pregnancy or not, right? Okay, so one more thing guys over here, that it will be preventing the pregnancy. It's not that already the female is pregnant and now if she is taking the pregnancy, or already the implantation has been, or implantation will not be there. I would say either the implantation have been happened or either the fertilization have been happened already, then it will not be able to help those kind of couples, right? Probably. So over here, Government of India also came forward, and Government of India came forward Okay, and they started this emergency contraception over here. They also started to give the levonorgestrel. Okay, and levonorgestrel, they are providing it with one name, right? They are providing one name, and what was that name? That is the easy pill. So government of India launched it, okay, with the name that was easy pill. Okay, and with that, the private firms have actually launched it with iPill, right? So that is the thing over here. So it is actually coming under which program? That is coming under National Family Planning Program. So all of these programs which I'm telling you, that they are coming in the NFPP, National Family Planning Program. In the next chapter we'll be talking about that in detail. So National Family Planning Program, under this particular program, right, under National Family Planning Program, right, under this particular program, basically they have released what kind of pill? That is the easy pill. Okay, so please do not forget that. Okay, one more thing over here, that it is actually available as SMS package at ₹3 per packet, right? So basically, social marketing scheme. So it is available under that scheme as well. Okay, now let's talk about the permanent methods. Now let's talk about the permanent methods. In the permanent methods, I told you that basically we are having two options, for the one for the male, one for the female. For the male, I told you what? For the male, I told you that was vasectomy, and for the female, there is tubectomy, right? Okay, so if you talk about first one, right, that is vasectomy. Vasectomy will be done for whom? Vasectomy will be done for men, obviously, right? Vasectomy will be done for men, obviously, right? And over there, okay, this particular picture which you are seeing right now, this is the easy pill picture, right? Easy pill picture which we had just now talked about, right? This is the oral emergency contraceptive pill for the women. So स्त्रियों के लिए खाने की आकस्मिक गर्भ निरोधक गोली, right? Okay, so this is the thing over here, one tablet. Okay, and what will be the dose over here, guys? That will be the 1.5 mg, one tablet within 72 hours. Should be taken within 72 hours. Free supply, not for sale, right? This is the easy pill. Okay, once we are clear with that, right, now we shall move on to the permanent methods. And first method is the vasectomy over here, that is done in the men. Nowadays they are saying that there should be non-scalpel if we want to promote the vasectomy among the community over there, right? So we should be taking some step which should be not cutting the skin over there, right? So we should be actually doing the vasectomy without scalpel, or I would say with very, very minor cut. So this kind of surgery is actually the most common one which we are using, that is a non-scalpel vasectomy. Non-scalpel vasectomy, that is the most common approach which we are actually taking these days. And if we want to promote it, we need to actually do that. For the female purpose, we shall do the tubectomy, right? We shall do the tubectomy for the female, obviously for the woman. Okay, and here we are actually doing very commonly, that is a modified Pomeroy's technique, because it is having very lowest failure rate. So modified Pomeroy's technique, right? Modified Pomeroy's technique or modified Pomeroy's tubectomy. Okay, and it is having a lowest failure rate. So very low failure rate is there, lowest failure rate, with a failure rate of around 0.1 to 0.3%. 0.1 to 0.3%. Okay, and basically some tubectomies can be done laparoscopic. So laparoscopic tubectomies can also be done over there by the trained, obviously by the trained gynecologist. So laparoscopic tubectomies might be performed, right? Might be performed by the trained gynecologist, right? For the females over there, right? And basically it is done at the level of CHC level. If you talk about the government sector, it is done at the level of CHC level at least. So community health center, I told you in the, earlier also in the healthcare system, that healthcare system of India, that I told you that specialist will be present at the level of CHC, and at the PHC medical officer will be there. 3 medical officer, I told you, medical officer in charge, medical officer Ayush, and medical officer from the dental side, right? Okay, so once you talked about tubectomies, right, and here you are seeing that what you are seeing, this is the vasectomy, right? What they are doing actually here, they will be taking the access from the testicle side, and here you are seeing these are the epididymis which you are seeing over here coming, right? So these are the vas deferens basically, and over there what they will be doing basically, okay, these are the vas deferens, okay, near the epididymis. So here what they will be doing, they will be cutting it and they will be tying it like this, right? So this is the vasectomy, right, which they are using basically, and this is the non-scalpel vasectomy we are doing these days, right? So over here they will be actually cutting the vas deferens and tying it both the sides, right? And that's how the vasectomy will be done, right? So that is the thing over here. Okay, so in this section we had to talk about the OCPs, we had to talk about the the other kind of contraceptive methods, we had to talk about the intrauterine contraceptive devices, we had to talk in the previous section only. In this particular section, we had to talk about emergency contraception, we had to talk about the OCPs, then we had to talk about Antara, we had to talk about Chaya, we had to talk about some subdermal implants and all of these things, right? And now we shall move on to some of the MCQs, right? Some of the MCQs, so that we shall know that where do we stand. So here the first MCQ says that the highest contraceptive failure, guys. Highest contraceptive failure is seen. I told you OCP is very nice as far as contraceptives are concerned. IUCD is having very good rates, having very low failure rate over there. So over here, the spermicide is having the lowest failure rate. So spermicide will be the answer over here. So over here, the answer should be the spermicide. Okay, right. Now let's move on to the next question over here. A woman from the village delivers her 7th baby and she wants the contraception now, right? Obviously very late, but okay. So what is the ideal time for the immediate postpartum? I told you several kind of IUCD techniques over there, several kind of IUCD insertion. I told you post-placental, post-placental, postpartum, post-abortion, right? I told you what is the interval IUCD insertion, right? All of these things I have discussed over there. So if you talk about the postpartum, I told you one is the post-placental. Post-placental means within 10 minutes of the delivery of placenta. Then I told you postpartum. Postpartum means after 10 minutes of delivery of placenta to the 48 hours. So over here they are asking you post-placental or postpartum. They are talking about the postpartum insertion over here. So postpartum means after the 10 minutes to the 48 hours. So over here that option is not available over here. Immediately after the baby expulsion, that will be after the baby expulsion, there will be the placenta expulsion, and that will become like placental, post-placental. So they should not be the option. 6 months ruled out easily, 6 weeks ruled out easily. So within 1 week, yes, because 48 hours is coming in that period, right? 48 hours is coming at that period. So over here answer will become the within 1 week of the delivery, right? So read the questions very, very carefully, guys. Now next question, let's move on to the next question. Here, unmet need for the contraceptive means what? Unmet need for contraception is actually using for that particular term, basically, who are actually particularly they should be the married woman, right? They should be the married woman, but they do not want to use any kind of barrier method, or they do not want to use any kind of OCPs, right? So these kind of contraceptive methods they do not want to use. They are actually coming under the unmet need for the contraceptives, right? Usually they are actually coming below the 20 years of age or nearby the 20 years of age, these groups of women. So they don't want to use any kind of OCPs, they don't want to use any kind of barrier methods, and still they want the unprotected intercourse. So due to the unprotected intercourse, there is very high chances of pregnancy also, we know that, right? Yes, we are having some kind of natural method, but still we are having high chances of pregnancy, right? So those kind of groups will be called as the unmet need for contraceptives, right? So over here we are saying that family planning in those who are not using any contraception. Okay, so that will be the group which are coming for the unmet need for contraceptive, right? So please remember that as well. Next question is, guys, they are asking you definition of the Pearl index. So I told you in the last session only that what the Pearl index, it is actually talking about the contraceptive failures, right? Contraceptive failure rates. So it's talking about the contraceptive failure rates in the, okay. And if you talk about the Pearl index, actually I told you the ratio also, right? That number of total accidental pregnancies by total months exposed multiplied by 1200, that was the formula over here. And I told you it is actually always expressed per 100 women years, HWY, 100 women years. So over here first and second option should be ruled out straight away, and third and fourth options are left. So over here failures per 100 or 1000, failure per 100 women years of exposure, right? So 100 women years of exposure. So over here the C option should be the correct one, right? Okay, I hope you have answered that very well. Now next question might be some challenging, but still, guys, it's easy only. Let's try to solve that. Okay, so 100 females use contraceptive for 1 year, and there is one failure 100 women per 100 women years, right? So they have given us the Pearl index. They have given us the Pearl index, that is 1 per 100 women years. Now they are asking you how much is the accidental pregnancies rate. So over here, what was the formula, guys? Again, Pearl index equals to total number of accidental pregnancies. So total number of accidental pregnancies multiplied by 1200 divided by total months of exposure, right? Total months of exposure. So over here, if I will see, then Pearl index was given. Pearl index was 1 over here, so I have mentioned it. Total number of accident pregnancy, let's say it was X. We don't know. Let's say it is X, right? We need to actually calculate this. And total months of exposure, they are talking about 1 year over here. So 1 year contains how many months, guys? It is containing the 12 months. And formula says that multiplied by 1200, right? So this becomes, so now the equation, if I will be opening up, so it will be equal to X equal to, So it will be cancelling out each other and it will become 100. So x equal to 1 by 100, right? So that I will be having answer as 0.01. So this should be my answer, guys. 0.01 should be my answer over here. Okay, and that is the value of x. So x means, I told you, that is the accidental pregnancies. So they wanted to ask us accidental pregnancies, right? How much is the accidental pregnancy? So 0.01 should be the accidental pregnancies over here, right? So over here our answer becomes what? Our answer becomes the 0.01. Understood? So that's how you shall apply this formula in the Bold index, right? Once you will be solving 2 or 3 questions by your own, right, you will be perfect in this one. Contraceptive contraindicated during the lactation, guys. Contraceptive contraindicated. This is very important. Which contraception you should be using in the lactating female and which you should not use. I told you in the class itself that what is the contraceptive choice, or what is the contraception of choice in the lactation amenorrhea. That was progesterone only pills, mini pills, right? So over here, which pill should not be given in the lactation amenorrhea or during the first 6 months of the breastfeeding? That was during the lactation period. That was OCP. OCP should not be given. That was a relative contraindication. I told you already, right? So over here, combined OCP should be the answer over here, right? They asked you what is the contraindicated, contraceptive contraindicated during the lactation. That is lactation period, right? Breastfeeding period. So that is the thing. Now, 7th one, best contraceptive for the lactating female. They are asking you this time. So best contraceptive, I told you, progesterone only pills or the mini pills. So progesterone only pills or the mini pills should be the answer. So that is the D option. So these are also called as the mini pills. Okay, right. These are not OCPs. OCPs are containing both estrogen and progesterone, but these are the progesterone only pills. These are called as the mini pills. Okay, right guys. So now let's talk about the next one, mechanism of action for the combined OC pills. Mechanism of action for the combined OC pills. So combined OCPs, it means the oral contraceptive pills. It means the estrogen plus progesterone. How it was preventing the pregnancy? It was actually causing the anovulatory cycles. So anovulatory cycles means, yes, so prevent fertilization, prevent release of ovum from the ovary. Yes, that was the thing over here. So actually they are preventing the release of the ovum. So basically they are making the anovulatory cycle. So that becomes the best answer over here, right? That becomes the best answer over here. Okay, right. Now 9th one, OCPs give protection against. So I told you it is promoting some malignancies and it was preventing some malignancies. So I told you, if you are talking about the prevention of the pregnancy, I told you ovarian cancer is the best option. Then endometrial carcinoma might be the answer. But over here, and it was promoting what? It was promoting the cervical cancer, best answer. Then breast cancer, and it was also promoting the hepatocellular carcinoma. So if you look at the option over here, breast cancer, it is actually promoting, not protection. No protection. So ovarian cancer, it was protected. And with that, I told you endometrial carcinoma can be the answer as well if the ovarian is not given in the option. But over here, they have very well given the option of ovarian cancer, so that will be the answer over here, right? So breast cancer, it will be promoting actually, not protecting. It will be promoting actually, and same with the hepatocellular carcinoma, it is actually promoting, not preventing, right? So I hope you have enjoyed this particular lecture, right? And I will be seeing you in the next one with the National Family Planning Program. So thank you so much, and bye bye.